next 2 days of really quite exciting discussion that we hope to have here. As the title of the symposium suggests, we'll be talking about emerging, and for some of us, re-emerging perspectives on health and health policy. And hopefully this morning I can try to explain why that particular title for this symposium. First of all, let me thank all our guests who've flown in from many different parts of the country to join us, to help lead our discussion, to provoke us to think openly and broadly about the issues that we're about to describe. And to those of you who are joining us from the campuses of Mexico, welcome. You come and are making great sacrifice in your schedules and time as well. So we greatly appreciate you helping us try to move this ball ahead in looking at the question of health equity. Why make equity in health a priority in the first place is probably the first question I should try to answer. And I think it's probably related to the fact that we've seen general improvements in the health status in our country over the last 50 to 60 years, but that improvement in health status as a nation really masks considerable inequities in health. Less privileged folks experience excess risk of all diseases within each age and among both men and women. And increasingly, we see a health divide during a period when health of the population of the whole is improving. And it's a tragic paradox that deserves our attention as a society. What's become very clear over the last half century is that there really is no biological or predetermined factors that are causing these inequities. And therefore, many of us over the long period of time now have begun to look at the related social, economic, and behavioral factors that influence this difference. In many ways, it's really about context, the context of an equity-oriented health policy in our nation, or the lack of one. I think many of you who are associated with the center have seen this chart from me before. I really talk about, as a starting point, many of us often talk about the primary causes of death. And yet most of us in this room, and I think everybody in this room agrees, these aren't at all the causes of death, but rather the outcome of the inequities that we see. And, that I try to demonstrate in this little chart as a way of organizing the work that we do here at the RWJF Center for Health Policy, which is really to look at these differences in health outcomes that are related to inequities in medical care, in the context within which individuals and families make their choices about their own behaviors and about the behaviors available, and make choices available to them for their family and their communities. And within that is that social and economic context that's embedded within also the larger physical context within which people live. Sorry about that, I'm trying to juggle two different things here. And these differences really are differences in incidence, prevalence, mortality, and the burden of disease and other adverse health conditions between specific population groups, which get often referred to as health disparities. But what are the causes of these differences? And I think today and tomorrow we're going to be exploring old frameworks and new frameworks for understanding how the social, the economic, and the political factors, that is, racism, income inequalities, neighborhood resource differences, play out, as well as the issues around medical care resource differences, medical care distribution, and medical care quality differences that exist in our society. Taken together, there are large elements that have been gathered together in a variety of different ways. Some people now call these things the social determinants of health. In my day as a graduate student, it was the social gradient of health. In other periods, it was called a variety of other terms, and I'll try to review some of the history of those frameworks. This is kind of a way in which we've been looking at where are there opportunities for additional research and opportunities, more importantly, for interventions. Really looking at three areas: areas of equitable opportunity, relationships between people, and the context within which people and societies operate to make health reasonable. Now, what do I mean by an equity-oriented health policy? I'm really talking about how do we facilitate that less privileged groups avoid health hazards and make the healthy choices an easy choice for them, as it is for many more privileged groups. Now, AHRQ has been tracking health disparities for the last decade, that divide across racial and ethnic groups, but largely has failed to see any major progress over the last decade. And one has to ask why. Is it lack of progress because we lack knowledge regarding what the causes are? I don't think so. I think really it's an analysis that requires us to think in terms of professional and political priorities, and that requires us then as scholars to think about the frames that we use for understanding the underlying factors at work. This chart that I'm showing you is in some ways a reflection of this concern for equity and equality. These are state rankings on access and prevention and treatment dimensions. You'll see the rankings of the states on the vertical, and on the horizontal you'll see state rankings on access. You can find your own state or your home state. Where do they rank? I hate to say it, but New Mexico, the pointer down there. Anyway, if you look at the very far little corner, for those of you who are living in New Mexico or who grew up in New Mexico, you'll find ours way down in the very corner. So it's not hard to find us. On the other hand, that's probably not the best quadrant for us to be in. So the question is, how do we move out of this quadrant? And the question is, are the people who are up at the far end, who are living in Massachusetts and Minnesota and Connecticut, are they really that much better off health-wise? Or is this reflecting a variety of other kinds of dimensions that we need to understand? Clearly, there's a huge distribution across our country. Now, this huge distribution plays out in a lot of different ways, but before I talk about that momentarily, let me just remind you that this isn't the first time we've seen this distribution, this huge difference in communities. In fact, Frederick Engels, in his work of 1844, called The Condition of the Working Class in England, was probably one of the first major works of epidemiology and medical sociology that in fact demonstrates these disparities in disease prevalence and outcomes. He shows them by occupational and environmental, related to occupational and environmental lead poisoning, repetitive motion injury syndrome. He demonstrates neighborhood effects on morbidity and mortality, all things that we are talking about today and somehow think we're discovering as social determinants of health. His particular focus looked at alcoholism and really understood and tried to explain this issue of alcoholism as really an issue that was rooted in the organization of the economic production of the time and the social environment of that time. Not long after, Rudolf Virchow, who's really often called the father of social medicine, also wrote about the epidemics of typhus and other infectious diseases that arose due to social conditions. In 1939, here in the Americas, Salvador Allende, probably best known as the deposed president of Chile, was before he was a politician trying to change the social and economic environments of his country, was a pathologist. And also in his work, La Realidad Médico-Social Chilena, which was published in 1939, provided a wide-ranging epidemiological study of the health and mental health of his people, looking at addiction and alcoholism. To quote one of his passages, and he says, "In the tavern, one finds a lighted and heated place, and friends for distraction, making one forget the misery at home. In short, for the Chilean worker, alcohol is not a stimulant, but an anesthetic." And in many places in our world, we see similar kinds of efforts, people seeking relief from the misery of home and the misery of work. So what I really think about is probably to provide you some definitions of the way at least I use these terms. Inequities, to me, are really preventable differences in access to resources, the kinds of resources that are distributed in societies, in our society, in an inequitable way. Money, power, services, programs. And inequalities are really preventable differences in outcomes, those things that we look at as morbidity, mortality, satisfaction, participation, the things that we've grown to call disparities. Some of your colleagues recognize and have pointed out that perhaps we've been using disparities in ways that erase the sense of injustice as a way to make it more palatable in a political environment. And certainly having been part of the Clinton administration's efforts to push forward the agenda of addressing racial and ethnic disparities, I don't think anyone would say that I'm not a pragmatic person, and many of the people that I worked with were not pragmatic. So perhaps we did adopt a language that erased the politically difficult decisions that needed to be dealt with. These definitions and this effort really raise some important political implications. It means that from a research perspective, that we often need to focus on societal level issues that are politically difficult to address. If we in fact were to deal with this, we would be dealing with redistribution of wealth. We'd be dealing with reconstructing work hierarchies. We'd be combating racism in all its forms, whether it's personal or institutional. We'd be dealing with the macroeconomic issues that need to be modulated to deal with the economic cycles that we see in the world. Probably more importantly, we'd be seeking peace as opposed to waging war on all fronts. The irony is that that we're in a period in which we've emphasized, at least over the last decade, increased research on disparities in health, and yet we've been pursuing politically policies that lead to increasing rather than decreasing disparities. I think that certainly that can be said for the period from 1980 on. And here's an illustration. As many of you know, I've been working with Federal Reserve Bank over the last year or so, in part working on American Economic Association summer program for minority students. And part of what we've been dealing with is how do we make sense of this information about income? This is just about income. This is not about wealth. Most of you will know about the 99% slogan. That was about wealth. And so these charts even look more dramatic in that sense. But this is just about wage income. So in 1976, the bottom 90% of our society earned 50% of the wage income. But by 2004, only about 30% of wage income was distributed or gained by the bottom 90% of our society. And as I said, the wealth distribution looks even more stark. For the work that we do here at the Robert Wood Johnson Foundation Center, trying to deal with inequities in our society, we're often looking at racial and ethnic differences because part of our mission is to increase the diversity of scholars who are trained in the social and behavioral sciences who can begin to address these issues. And part of this symposium is trying to find the frameworks, the academic frameworks that allow us to come up with policy resolutions that move us to a much more equitable society. So how might we achieve that equity in health? Well, there are a lot of different ways, and I hope that we'll explore some of them over the next 2 days. You know, we clearly have some follow-up to do, and everybody's got to do their own contribution to getting us there. One of the issues that I think many of us in the 90s thought we were doing was using a politically neutral definition that we could get every party behind to support the need to seek diminishing or reducing. We never used eliminating health disparities in those days. And I think that's a reflection also of that effort to try to create a politically neutral definition. But I don't think we should shy away. We need to be bold, and in many ways, as the top of this chart says, we need to have courage to think boldly and to think the unthinkable. So with that, I want to thank you for joining us today. I hope these comments have been provocative enough to get our conversation started, and I'll turn over the podium to our first panel. Nancy?
So thank you all for being here this morning. As director and co-founder of the Institute for the Study of Race and Social Justice located at the Robert Wood Johnson Center for Health Policy, it is my deep honor to serve in this role as moderator of our first panel. I especially want to thank and acknowledge the students, faculty, and staff that made this compelling symposium possible. Before I introduce Dr. Thomas Leviste, I would like to give you a brief overview of our session format. First, we will have a presentation by Dr. Leviste that will be about 45 minutes, and then we will have comments and questions from our two invited discussants. The first discussant will be Dr. Lisa Kakari-Stone, Robert Wood Johnson Foundation Senior Fellow and Associate Professor of Family and Community Medicine. Is she here? Right here? So Lisa will be our first discussant, as well as Patricia Rodriguez, Robert Wood Johnson Foundation Doctoral Fellow in Psychology, if she could just raise her hand. And for the last part of the session, we will have at least 30 minutes for questions and answers from all of you. And now it is my great pleasure and privilege to introduce Dr. Thomas Leviste. Dr. Leviste is currently the William and Nancy Richardson Professor in Health Policy and Director of the Hopkins Center for Health Disparity Solutions at the Johns Hopkins Bloomberg School of Public Health. He earned a BA from the University of Maryland in Eastern Shore and a PhD in medical sociology from the University of Michigan in Ann Arbor. In 2008, Dr. Leviste received the Innovation Award from the National Institutes of Health, National Center on Minority Health and Health Disparities. Dr. Leviste's research and writing has focused on three broad thematic research questions. First, what are the social and behavioral factors that predict the timing of various health-related outcomes? Second, what are the social and behavioral factors that explain race differences in health outcomes? And third, what has been the impact of social policy on the health and quality of health for African Americans. And I'd add a fourth, which is really very well dovetails with the mission of the Institute for the Study of Race and Social Justice, and that is to establish empirical, conceptual, theoretical, and methodological clarity about race and improve and build on transdisciplinary research. A prolific scholar, Dr. Levis, has published 2 books entitled Minority Populations in Health, as well as Race, Ethnicity, and Health. Dr. Levis' numerous articles have appeared in a variety of journals, including Social Science and Medicine, the American Journal of Public Health, the Journal of National Medical Association, and some of his titles include are Low-Income Women. I'm sorry?
Embarrassing.
Well, we're gonna have to go out for drinks afterwards, and
Okay,
we'll continue. A recent 2011 publication of the Journal of Epidemiology and Community Health is of particular importance for the ongoing national conversation on the proposed changes to how race and ethnicity will be captured in the 2020 census. In his article entitled, Are Black Hispanics Black or Hispanic? Exploring Disparities at the Intersection of Race and Ethnicity, Dr. Levis and his colleagues point to the importance of collecting multi-dimensional data on race and ethnicity for Latinos as a way of interrogating inequalities. Again, we are truly honored to hear Dr. Thomas Levis talk about his work in making progress in understanding the causes of health disparities. Con mucho cariño, Nuevo Mexicano, please join me in giving a warm, heartfelt welcome to Dr. Thomas Levis.
Yeah, I tried to get her to stop. She wouldn't stop. But that paper, Black Hispanics, Black or Hispanic, it's a paper I've been wanting to write for over a decade. You know, many people don't know this, but I'm Dominican, born in the United States.
But you were cousins.
And so it's a population and a question that I've been interested in for a long time, but we just didn't have the data to even ask the question. And in order for us to even do that study, we had to compile 10 years of data to get enough people who reported on the health interview survey that they were Black and Hispanic. So this is really timely because the issues that I know you're working on really dovetail this whole question of identity and how do we self-identify and how is that data then used and what do we do with this? There's so much there. So, you know, I really appreciate you for taking up the mantle and working on this issue because it's an important issue, because important policy decisions are being made now that relate to resource allocation and how we define race, how we measure race and ethnicity, who gets counted is a big part of how these resources will be allocated. I also want to say that I'm also very happy to be here because I know Dr. Valdez has invited me before. I haven't been able to come, and I did want to come, and I'm glad I was able to come to your meeting this year. I've recently joined the board of the center, so I'll be down more often now and getting more involved in what's happening here. I've been very involved with your sister center at Meharry. As a matter of fact, I just flew here from Nashville when I was in Meharry. So I think this is a fabulous program that the foundation has created, and I'm happy to be able to support it. You know, I like to be a moving target. You know, when I first started working on these issues, and when I had my moment of discovery, I'm going to tell you about in a minute, that we had health inequalities. Could you imagine that? I didn't know that that was the case at one point. You know, and I would try to talk about the issue. You couldn't get a room full of people who were willing to talk about this issue. I mean, there was just no one who was tuned into it. So now we can actually have meetings like this and groups of people who are sitting around trying to figure out what's this all about and what do we do about it and how do we make change and how do we fix this. So I'm just so happy to be able to come to a meeting like this and see people who are trying to address this problem. But let me ask you to think back and imagine this society without health inequalities. Can you imagine that? How would we get there? What would it take? What would have to happen? It's a difficult thing to consider, right? Because for most of our conscious adult lives, we've known that these inequalities exist, and we fought and we've worked and we've thought about how do we eliminate disparities, not reduce, eliminate disparities. Eliminating disparities is worthy of life's work. Reducing them is not. So eliminate disparities is the goal. Well, I can remember back when I could imagine this society without health inequalities, because there was a time that I didn't know they existed. And I'm a little embarrassed to say that this was not, well, it actually was a long time ago, but I was pretty old. I was a graduate student. I was actually working on a PhD in political sociology. And I was so far into the program that I was working on a dissertation. And I know many of you in this room can relate to that point when you are working on that dissertation and the tedium, isolation, and boredom gets to you, where you just need something else to do, anything else to do. So I started taking this walk towards the federal building in Ann Arbor, Michigan, thinking that maybe I'll look into career opportunities with the federal government, maybe the Foreign Service, get as far away from this as I can get. And fortunately, the federal building was closed. So I kept walking to downtown Ann Arbor, Michigan. So if you've been there, you know it wasn't a very long walk, but I'm in downtown Ann Arbor, Michigan, and I find myself in this used bookstore. And I make my way over to the clearance section. Now, I'm at the clearance section of the used bookstore, right? Which tells you something else about the life of a graduate student. This is what you can afford. I'm looking for something to read. Actually, I'm looking to procrastinate, but under the guise of looking for something to read, anything to read that doesn't have a bibliography in it, right? Anything. And I come across this book. This is pretty dark, but it says A Night to Remember. This is the book that tells a story about the Titanic. Now, for the younger people in the room, this was before the film came out. So I hadn't seen the film, and all I had was the book. And what I understood happened that night was they hit an iceberg, they sunk, everybody died. I had no idea that there were survivors. So I'm reading through this book, and I come to this page where they're talking about survivors of the Titanic. So on this page, they're telling us, it's talking about who survived, the number of people that survived as a function of the class of ticket that they had. You know, first and second and third class passengers, and how many of them survived. So I start calculating the survival rates, which tells you something else about being a graduate student working on a document. I'm standing in the aisle at the clearance section of the used bookstore calculating survival rates, right? So I was gone. I was too far gone to not finish my doctorate at that point anyway. But anyway, here's the calculations. I've checked them now, and they are correct. The class of ticket determined who survived. So if you were a first-class ticket woman with a first-class ticket, 97% survived, 84% second class, and 55% if you were third-class ticketed. We find this, we do this analysis, and we see that there's this disparity, which is fascinating to me because I'm working on this dissertation on political sociology, and I'm trying to find ways of measuring quality of life. The dissertation was about black political empowerment and whether or not it had an impact on the quality of life, right? And I keep coming across these health measures, and this is how I actually find my way into public health. When I start seeing this, and I start becoming fascinated by these differences, that even in this instance where the whole ship did go down, who you were still mattered. Now, why would that be? The reason is that on the evening of April 15th, 1911, at 11:40 p.m. in the North Atlantic, there was not enough lifeboat space to accommodate all the people on board. And when it comes to scarce resources, and to be sure, space on the life raft was a scarce resource that night. Who you are determines who gets access to those resources. It seems to me this is a perfect analogy, perfect metaphor for the U.S. healthcare system. Big, expensive, fancy ship giving out unequal treatment, destined to hit an iceberg and destined to sink. And when it does, the results are going to be something like this. Who you are will determine how badly you're impacted by that sinking. So now you're saying, okay, this is an interesting, cute little story. This is 100 years ago. 101 years ago. This could never happen today, but it can. This is the U.S. airliner that landed on the Hudson River a few years ago. And I did not Photoshop this except to put in first class and coach class. And that even today, we don't have enough space on the life raft to accommodate all the people on the ships. Now, notice it's a health policy group, so I will take a moment and indulge one of my little tangents that I tend to go on these lectures and say, there is a set of policy decisions that happens that produces this picture. And when people think of policy, we often think of policy in terms of governmental policy. Government makes, legislatures pass law, and the law is the policy, and that's the end of the story. Nothing could be further from the truth. A set of policies happen to produce this picture. So, and some of that is governmental policy. So, government regulators did not say you must have enough lifeboat space on an airliner to accommodate all of the people on board. That's a government policy. Legislature did not pass a law requiring that. U.S. Air did not develop a policy that says we will not purchase an airliner that does not have enough life raft space for everyone. And the company that built this airliner did not pass a policy that says we will not build airliners that don't have enough space, right? So there were some corporate policy decisions made as well. So as policy actors, we have to be conscious of the fact that policy occurs at many different levels and in many different ways, and these policies impact people just out, corporate policy can impact people, impact society just as dramatically as governmental policy. Okay, that was a tangent. I'm going to need to steal 5 more minutes from somewhere else, so I'll speak a little faster. Now, for most people, knowledge of this issue of health inequalities comes to their consciousness with the publication of Unequal Treatment, Institute of Medicine's fine report, which compiled evidence that made it impossible to ignore the fact that we had a problem. Now, this wasn't the first report published on this topic, not the first government report. It wasn't even the first report from the IOM on the topic. But this report has been more successful than the others, and the reason I believe it's been so successful is that in the past, the reports would come out. For example, the Secretary Heckler in 1985 publishes a report on Black and minority health, which is a multi-volume compilation of statistics that shows disparities in health status, disparities in criminal justice, disparities across a wide variety of areas of social status, and is a monumental document and very important historical document that did move some policy or some federal resources in this direction. But what would happen when these reports would come out is that people would say, well, we have these differences, and at the time we didn't say disparities, we said differences. We have these differences by race, but it's biological, we can't really fix that, or it's just socioeconomic status, it's not really race or ethnicity, or this is really a healthcare access problem, and that's bigger than what we can do in the healthcare industry. So what would happen is that it would lead to inaction. But in this report, what they did was they limited the report to well-designed studies published in quality journals that were based on US populations that had health insurance, that showed up and got access to care, and that said, what is the difference in the quality of care received among people that are insured and did seek care and did get into the system? So it's narrowly limited so this is not really a report of health disparities, it's really a report of quality of care among insured people. And once you take all of the excuses off the table, it becomes impossible to say, we don't have a problem. This is why this was such an important piece of work. And one of its primary functions was to bring to the consciousness of the country this problem. Here's a quote from a prominent policymaker who says, a key test of any new system is its ability to provide access to quality care for the poorest and sickest among us. The elimination of health disparities must be a critical goal. No American can be left out. Anybody know who said this? Ronald Reagan. Wrong, but close. This was former Speaker of the House, Newt Gingrich. I'll give you one more. African Americans die sooner than other males do, which means the system is inherently unfair to a certain group of people, and that needs to be fixed. And it does. Any ideas who said that? You're not going to be graded, it's okay. Well, this was President George Bush. So the point is, awareness of the problem is not the issue. It's not that they're not aware that there's a health disparities problem, because they can accurately cite that the problem exists. Now, of course, the president was not announcing or making this quote in the context of announcing a new initiative to fix the problem. In fact, what he was doing was arguing that African Americans should support his efforts to privatize Social Security, because since they died younger, their families would inherit their benefits. Political considerations aside, he was most assuredly accurate. There are disparities. And ever since this report has come out, we've argued that we should do something about disparities from primarily a social justice perspective. We should do something about health disparities because they are inconsistent with the values of this society, because they're wrong, because fixing it is the right thing to do. And I am absolutely convinced by the social justice argument. But I, along with some of my colleagues in my center, got the idea that perhaps we can help to create another set of arguments for why we should support the elimination of health inequalities. And we did a report to try to bolster the utilitarian argument. We did a report called The Economic Burden of Health Inequalities in the United States, where we calculated the cost to the US economy of having health inequalities. The cost in terms of lost productivity, the cost in terms of unnecessary use of healthcare services, and the cost in terms of premature death. And we calculated those costs to be over $1 trillion, $1.24 trillion over a 4-year period of time. So when you hear the argument that we can't do anything to make change because it's too expensive, we can't implement this new program or this new policy or this new direction because it costs money. The response is, it also costs money to not do anything. It's expensive. It's very expensive, and it's a cost that we should not continue to bear as a society. Now, on to this issue of health inequality. So I actually used to update this chart every year, and I stopped in 2003 because it just seemed pointless, because it's the same chart. The pattern remains the same, although the numbers fluctuate a bit, but the pattern is the same. And the pattern shows that we have these inequalities, these differences across racial and ethnic and gender groups, which appear to be intractable. I think that's the ultimate, depiction of health inequalities. But then we have health care inequalities. And here I put this up. And this is, if you just focus on this first line here, limb amputations, this is from work done on Medicare population. So these are all patients who have the same health insurance access. And if you look at the high level of use, the disparity in use of limb amputations, more than 3 times more likely to receive limb amputation for African Americans compared to whites. Limb amputations, of course, are the result of untreated and poorly managed diabetes over an extended period of time. Another example would be, this is a study done by some guy named Leviste a few years back, where we went into hospitals, 3 hospitals in Baltimore, and did medical record abstraction to identify patients that were candidates to receive cardiac catheterization, and which is an invasive procedure to diagnose cardiovascular disease. These were all insured patients seen at the same 3 hospitals during the same time period. All of the patients in this study had the ability to pay. So this is not an access problem, because they all did get seen. This is not an insurance problem, but we find this disparity in quality, and we also find an overall quality problem because 100% of the white patients should have been cathed as well. So we see we have a quality problem overall, and we have this disparity in quality problem. And of course, these are procedures that were medically appropriate, for which that the hospital had the ability to provide the service and would have been reimbursed for it. So from an economic standpoint, the hospital left money that they deserve to have on the table. So this is a complex problem. It's not just a matter of nickels, of dollars and cents, because if it was, we would find overuse of cardiac catheterization, not underuse, which is what we're finding here. There's another study, this is from the VA, and I really like this one because in the VA, of course, the providers are on salary, the patients have the same insurance, and this is for revascularization, whether or not, these are patients who had been cathed, been diagnosed and determined that they need some sort of procedure to revascularize, for revascularization. And we find a dramatic disparity as well as, again, a quality problem because 100% of these patients were appropriate candidates to get revascularization. So we've got a quality problem and we've got a disparities in quality problem in the United States. So we've done a lot in terms of devoting resources, throwing money at, and having meetings and discussions around health inequalities. But unfortunately, I'm here to make the heretical comment that I think that most of what we're doing about health inequalities is going to fail. And I think most of it's going to fail because we haven't yet stopped to take account of what is the diagnosis. Why do disparities exist? Which is the core of the question that I asked when I opened my comments, which was, imagine the society without these disparities. Why do they exist is the question that we'd have to answer next, and then what do we do about it? And I believe that most of what we're going to do is going to fail. Most of what we're doing is going to fail because most of what we do has been focused on health care solutions, and we haven't yet taken account for what the diagnosis is, why we have this problem. And let me just go over the 3 most common explanations that I get at dinner parties when I talk to people about what I do, and they say, oh, well, you know, this is a biological thing, you know, or this is really about access to health care, or this is really about socioeconomic status. Let me just make a few comments about each of these arguments. First, the bad genes argument. So how many of you here are familiar with this drug, BiDil? Or let me ask it the other way. How many are not familiar with BiDil? Okay, that's a lot. All right, so I'm going to have to do my Reader's Digest version of what this drug is about. So for those of you that are the BiDil aficionados, forgive me for what I'm going to do, but I don't have a lot of time to explain all the nuances of this one. Okay, here's what BiDil is about. BiDil is a drug that was approved in 2005 by the FDA for use in only one racial group, African Americans. This is the first drug ever approved for use in one racial group. Not 1905, 2005. Now, BiDil is a drug that treats congestive heart failure, a debilitating disease, about 500,000 new cases per year in the United States. Very expensive disease because of the amount of healthcare resources they use, and with a prognosis of only about 5 years. So it's a really bad disease that costs a lot of money for an inevitably bad outcome, right? So it's a real problem. Now, in the 1970s, new classes of drugs for cardiovascular disease were coming out onto the market. Calcium channel blockers, beta blockers, things that we now take for granted. They were new in the 1970s. And we're getting really good results with these drugs. So a group of physicians started to discover that by combining these new classes of drugs with 2 generic drugs, I have the hardest time remembering the names of those drugs. 2 inexpensive generic drugs combined with the beta blockers or calcium channel blockers was having a really good effect. So someone had the idea that let's do a study to see if this is really an effect or is this something anecdotal that we're getting in our practices. So they do the study and they find a dramatic positive impact of this combination therapy. And they published this article in the New England Journal of Medicine. And this was an important discovery because the benefit was huge. So now they get the idea that, well, maybe what we can do is we can combine these 2 drugs into one pill, get a patent on this new pill, and then there would be this financial windfall that we would get because of it. So they do that. They get this patent on the combination drug, and then they get ready to come to commercialize it, and they go back to FDA and say, okay, we're ready to come to market with this new drug, and FDA says, no, you can't do that. Well, why can't we? Well, because that New England Journal of Medicine article you published was fine and all, but it was not done to FDA standards, so you need to do a new trial.